Hello everyone, hope all of you are doing well. We have received a very good response to some of the recent videos on updates in internal medicine. In the same series, today we are going to discuss about one more KDIGO 2026 update on AKI and acute kidney disease. Today we will cover it shortly. What are the major changes and what we should be aware of when we are handling cases of acute kidney injury? Mainly, the shift has changed from functional to structural changes. So in 2026, they have integrated few important things, mainly to detect acute kidney injury early. Instead of functional markers like creatinine, we have to focus on utilizing structural biomarkers such as NGAL and TIMP. This is the first thing. Then they have specifically focused upon acute kidney disease. So we previously used to focus mainly on acute kidney injury and chronic kidney disease. So in between whatever the gap was there, that they have bridged using acute kidney disease, which we will be discussing in the upcoming slides. Then there are clear recommendations for renal replacement therapy in acute kidney injury. So all these things we will be discussing. First of all, for acute kidney injury, the definition almost remains the same. That is nothing but, for example, if we focus on functional decline, serum creatinine increase by more than or equal to 0.3 in 48 hours or more than 1.5 times of baseline within 7 days. And regarding urine output, it is the same thing, less than 0.5 ml per kg per hour for more than 6 hours. If it remains like that, we can consider it as acute kidney injury. The added thing to this functional parameters is about cystatin C. That is, increase in cystatin C by more than 1.5 times of the baseline within 7 days. So this is an addition we can consider. Plus, they have focused more upon the structural damage. For example, elevation in biomarkers of kidney damage, as mentioned in the previous slide, NGAL or TIMP. If these are available in your settings, then we have to utilize these so that we can identify the acute kidney injury earlier. Then AKI is being divided into two things. One is transient AKI, that is if functional decline is of less than 48 hours. Otherwise, the second thing is persistent AKI, if it is lasting for more than 48 hours up to 7 days. Why this division is important? Those individuals who are having persistent AKI, that is if the AKI is lasting for more than 48 hours, the chances of CKD in them will be quite higher. So we have to be carefully monitoring these individuals. Coming to the baseline serum creatinine decision problems. See, the thing is, even though they are stressing more upon these newer biomarkers, in Indian setup, it is quite difficult to adapt to these newer molecules. So still, we depend upon serum creatinine only. We all know that serum creatinine lags by minimum 48 hours from the structural damage. So that is the major disadvantage of using serum creatinine. That's why they are introducing those molecules which will be raised earlier. But whenever a patient presents to hospital with already deranged creatinine value with no previous records, so how we should assess acute kidney injury in that case? So they have advised few parameters. For example, we can verify the patient's serum creatinine in last 8 to 365 days. If any values are available, we can compare it with the present value. Suppose it is not available, then at the time of admission, whatever is there, we have to consider it. We can utilize back calculation method. That is nothing but we know a formula for calculating GFR. Like we will be using multiple formulas, right? Like CKD, EPI or MDRD, modification of diet in renal disorders. So MDRD formula we will be using. So what they will say is, when the individual presents with deranged creatinine with no other previous records, so in that case, consider the individual as having GFR of 75 as considered normal for a healthy individual. So using MDRD formula, keeping the target GFR of 75, we have to fill some of the variables like age, gender and all. With this back calculation, we will be getting the serum creatinine for the target GFR of 75. So that will suggest the baseline creatinine. So we can utilize this one. For example, a 60-year-old individual presents to us with creatinine of 3, for example. So in that case, using MDRD formula, keep the target GFR as 75, fill in the variables like age, that is 60 year, gender, male gender. Once we enter all these variables, we will be getting the serum creatinine. That will be baseline for that individual. So in this case, suppose we get the value as 1.0 as the baseline creatinine. Now this individual has presented with 3, right? So it is nothing but 3 times of the baseline. So definitely this individual is fitting into stage 3 of AKI, right? Like that we can decide the severity of AKI. But the disadvantage of utilizing such methods is, for example, in elderly, definitely the muscle mass will be lesser. So their baseline creat might be even less, for example 0.6 or 0.8 kind of thing. So in that case, we might be underestimating the severity of AKI. This possibility will be there. Otherwise, if the individual is a known case of CKD, if their baseline creatinine itself is 1.8 or 2, right? So in that case, if we utilize these formula, we will be thinking that there is no much changes in the creatinine. So we will be under treating this individual. So these differences will come if we utilize this formula. But otherwise, in majority of the cases, we can utilize this one to know the baseline creatinine. Then we have to know about the biomarkers curve, when they will rise, when there will be fall in their levels. Probably we all know the similar graph is applied when we read about cardiac biomarkers like CKMB, troponin, all those things. Similarly, what they have shown here is some biomarkers, for example NGAL or TIMP, will rise in their levels within 4 hours of acute kidney injury. So these we can utilize instead of creatinine, which will be rising by 48 hours. So there will be a lag by 24 to 48 hours. So this much delay can be prevented if we utilize these molecules. Again, the problem is in Indian setups, it is quite hard to have the laboratory to get these parameters in present scenario. But as you can see, at least if these are not available, we can utilize cystatin C. This will be rising within 24 hours of the injury. So at least that time lapse of next 24 hours will be saved. So this is the importance of biomarkers which we should utilize in treating subclinical phase of the acute kidney injury. Coming to some of the guidelines on hemodynamic and fluid protocols, they have clearly mentioned for fluid resuscitation in AKI, use buffered crystalloids as the first line volume expanding agents, but do not use colloids like albumin or gelatin, starches, etc. But if the individual is having traumatic brain injury, still the fluid of choice will be 0.9% saline. This we have already discussed in one of the previous videos of updates in sepsis management. And what will be the hemodynamic targets? It will remain the same, mean arterial pressure of more than 65. We can utilize the vasopressors. But when it comes to vasopressors or inotropes, remember, do not use low dose dopamine. Previously, we used to think that low dose dopamine will help in kidney protection, but there is a strong recommendation against the use of low dose dopamine in case of acute kidney injury. Then what about diuretics? Use diuretics to manage clinically significant volume overload. It's not like patient is having acute kidney injury and oliguria and we will be using diuretics to force the kidneys for diuresis or to get the urine output. Do not follow such things. If the patient is in acute kidney injury, only if you notice volume overload, in that case use diuretics. Otherwise there is no role of diuretics in AKI. And remember, do not think using diuretics we will be getting urine output and we can delay renal replacement therapies. This is a wrong concept. So the first part was about the biomarkers which we have mentioned in the first slide. Then they have focused upon AKD as well. As told previously, we were focused mainly on the AKI and CKD. but that whatever gap was there, which will be filled with acute kidney disease. So the timeline we should know. AKI, it will be 0 to 7 days, whereas CKD, it will be more than 3 months. Then what is the role of AKD? It will be between 7 days to 3 months. In that case, we have to follow up the individual. Why they have stressed so much upon acute kidney disease is, many times patient will be having some acute presentation with AKI, and we will be treating, and there will be improvement in AKI. But patient will be asking for discharge, or they will be discharged when we see improvement, but not that the RFT has reached baseline. So in that situation, we need to be more vigilant to follow up the case, because those AKI cases who have not reached the baseline will be at risk of developing chronic kidney disease. So after 7 days till 90 days, we have to be following up with the patient, and there should be strict avoidance for NSAIDs, contrast agents, and any medications if they are using, it should be renal adjusted dose, because this 7 days to 90 days, whatever the time is there, this will be the window period for developing chronic kidney disease. So our duty in treating acute kidney injury patients is, if they are able to follow up after 7 days regularly till 90 days, well and good. Otherwise, while discharging, instruct them to avoid NSAIDs, contrast agents, and confirm the dosage of any medications which they are taking with physicians or nephrologists. This is the importance of stressing so much about AKD. Next is about renal replacement therapy in case of acute kidney injuries. So now there are clear guidance about when to start and when to stop renal replacement therapy. Mainly the recommendation is delay renal replacement therapy as long as there is no life-threatening condition like refractory hyperkalemia or severe pulmonary edema. So we can wait, because to avoid the risks associated with dialysis such as catheter related infections or hypotension. This is first thing. Then when to utilize renal replacement therapy, the recommendations remain the same. Probably we all know about that AEIOU, which I have already discussed in one of the short videos. So refractory hyperkalemia related to electrolytes or uremic symptoms like encephalopathy or pericarditis, overload, acidosis and all. So these will remain the same thing. Then which modality to utilize? We know that CRRT, continuous renal replacement therapy, will be ideal in critically ill individuals and those who are having hemodynamic instability like unstable BP or those who are on vasopressors. Otherwise, if there is any head injuries, in that case also choose CRRT. If these are not there, hemodynamic stability is there, then we can go ahead with intermittent hemodialysis. What about SLED? As we know, it is a cost effective strategy. So in the similar individuals who are having the parameters as for CRRT, in low resource ICU settings, we can go ahead with SLED. Overall, the recommendation says that we have to allow the individual to recover on their own. There should be physiological recovery as much as possible. Physiological recovery. That is, the individual has to produce urine on their own without requiring dialysis as much as possible, unless there are some life-threatening conditions as mentioned, refractory hyperkalemia or severe pulmonary edema. Now we got to know when to start and which modality to utilize. But it is also important to know when to stop renal replacement therapy. See, if the individual is having urine output of more than 400 ml in 24 hours without utilization of any diuretics, or else if urine output is more than 2 liters in 24 hours using diuretics, or if the creatinine clearance is more than 15 to 20. In these situations, we can stop renal replacement therapy. The dosage, it is advised to keep it low at the rate of 20 to 25 ml per kg per hour, and do not use high volume hemofiltration because it has not proven to be of any extra benefit. Instead, the harm will be more if we proceed with high volume hemofiltration. That is nothing but 35 to 40 ml per kg per hour. So instead, always choose with 20 to 25 ml per kg per hour of hemofiltration. This is one more specific guidance upon the dosage of CRRT. Hope the points are clear. Just to summarize, there are new biomarkers. Wherever the facility is there, we have to utilize those structural biomarkers so that we can detect the AKI early. Otherwise, in resource poor settings, the old parameters like creatinine and the real-time superhero such as urine output are still utilized. Only thing is, creatinine lags by 48 hours, that we all know. Instead, we can go ahead with urine output. If it is less than 0.5 ml per kg per hour for up to 6 hours, then we have to be more careful and we have to act fast in view of acute kidney injury. This is the first section about the newer biomarkers. Second one is about the acute kidney disease. So whatever the time gap was there, 7 days to 90 days, we have to be watching, we have to be following up with the patients and we have to instruct them to avoid nephrotoxic agents. This is about AKD to prevent development of CKD. Finally, the clear guidance about renal replacement therapy. When to start, what dose to utilize, that is low dose, then when to stop, especially after the physiological recovery, like if the urine output is as mentioned, then we can stop the renal replacement therapy. This was the short summary of KDIGO 2026 updates about AKI AKD. Hope you will utilize this information in your day-to-day practice. We will come up with such informative videos and the updates in simplified way for your benefit. So please subscribe and share these videos with your colleagues so that everyone can utilize these valuable informations. Thank you so much.